Welcome to the Interventional Glaucoma Podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
Welcome to the latest of the Interventional Glaucoma Podcasts. We're here today with Marc Töteberg-Harms and Cédric Schweitzer. Marc from Iowa City in the US and Cédric from Bordeaux in France. And we are here today to really drill down into some of the wealth of the studies and the data that's available on ELT, Elios, excimer laser trabeculostomy, because there's now a lot of studies and a lot of both retrospective and prospective collected data, as well as an RCT. And I think it's going to be very interesting to hear how we pick our way through that data and what conclusions we can draw from it. To dive straight in, really, and to kick off, Marc, you've been involved in collecting some of this data and really looking at ELT in some detail. The peer review publications have been a cornerstone for the development of the clinical evidence base behind this device. And I think there's well over a dozen studies now in the public domain already published, let alone the ongoing RCT that's out there. What do you think that this data is showing us? And let's start off with your own study, that the 8-year follow-up study.
Yeah, hi Gus. Thanks for having me here on the podcast. In 2022, we published retrospective data from combined phaco and ELT surgeries that I, when I was still practicing in Europe at that time, performed, and one of my colleagues performed at the University Hospital of Zurich in Switzerland. And we collected data with 8 years of follow-up. So the main findings that we have for this study, let's summarize them. We included about 161 eyes. Most of them had a diagnosis of not only primary open-angle glaucoma, but also pseudoexfoliative glaucoma, which we see quite often in Switzerland. And I think that's nice to have these two big groups in a study, the primary and also the secondary open-angle glaucomas. The patients had a pre-op IOP of about 19 on 2.3 medications. And we could significantly reduce the pressure to 15 on 2.1 medication at 8 years.
So that's 8 years of follow-up.
Yes.
So that's got to be one of the, sorry, I mean I'm just stopping you there in mid-flow, but I mean that's got to be one of the longest follow-ups we've got for any of the MIGS devices, hasn't it? I mean the Horizon study was 5 years.
To my knowledge, it is the longest follow-up that we have for a MIGS surgery at this time. I hope we get more, because it's important to not only look at short-term data. I mean, most MIGS studies are 1 or 2 years, which is sufficient to get them approved. But if we treat patients with a chronic disease, we like long-term data. So from trabeculectomies, we know 20-year data is amazing, and that's what our patients are referring to. But for MIGS studies, we don't have that. So yeah, that was very exciting for me to have this 8-year data.
Yeah, and I mean, something that I'm constantly sort of banging up against in clinic when I'm talking to my patients is that we talk about the success of these studies, we talk of the devices, we talk about the studies we've got, the trials and the research, and the patients say, yeah, but how long does it work for? I'm going to be alive for, God willing, 30, 40 years for some of our younger patients, and yet there am I saying, well, we know what it does for 18, 24 months, and they look at me like I'm crazy. They say, where's the data that applies to me? So that's why I wanted to stop you there, because I just kind of think that 8-year data, that's very valuable. And also, you said it was 160 odd eyes, is that right?
Yeah, 161 eyes. And I agree with you. I mean, that's so important. That's real world. I mean, we don't want to talk about 2 years when we treat glaucoma. We want to talk about multiple years. And the patient, I mean, a decade is more reasonable to a patient than if I tell them it works, as you said, 1 or 2 years. So yeah, we were excited to have this 8-year data. And again, the key findings were we could reduce pressure to the mid-teens. We could reduce medications significantly for up to 4 years. And after that time, up to 8 years, the medication remained less compared to baseline. Another very important finding from a patient perspective, and that was also exciting for me to see, only 13% of these eyes within 8 years required subsequent incisional glaucoma surgery or cyclophotocoagulation. So the majority of the eyes did not even need a secondary surgery and had just been treated with combined phaco and ELT, so minimally invasive glaucoma surgery. Complication rates, in addition, were very limited and favorable as a complication profile.
I'm definitely telling my patients that I'm expecting them to have a day or three of slightly more blurred vision than their next door neighbor after their, topical clear corneal phaco, but that's actually something that I want to see, because I love to see that little bit of blood reflux through a trabecular bypass procedure of any kind, just to really show and demonstrate to me that we've got connection to that distal outflow system. When you've got a decompressed anterior chamber, if I see reflux, I'm generally very happy. It's one of the few things that I actually record in the operating notes. And it's almost universal, I think, when you've got it right. So that is definitely good. Did you see much of a difference between the pure open angle and the pseudo exfoliative glaucomas? I mean, I know that you're not randomized or powered to show that in this, or was it just pretty much effective for both groups? Were you happy with both groups?
Yes. So we looked later at that and showed it as a poster, I think, at the American Glaucoma Society once. Surprisingly, the results between pseudo-exfoliative glaucoma group and the primary open-angle glaucoma group was very similar, with no significant difference. And that's also like very impressive if you think for clinical implication. Primary and secondary open-angle glaucoma seem to have the same result in regard to IOP reduction and medication reduction and safety profile.
Cédric's being very polite there and not butting in like I am. But I mean, Cédric, what is your feeling on this? I mean, which are the trials of the dozen or more trials and studies that we have out there do you really like to hone in on and support your evidence-based selection of a MIGS procedure, or would do so when you've got free reign of choice?
So thank you very much for your invitation and for the invitation to comment on the results of the Elios excimer laser treatment. I agree that it's interesting to see in the literature that the efficacy of ELT to lower IOP is approximately 25 to 30%, with a decrease in medication treatment of 1 to 2 medication in most of the studies. It's also interesting to discuss the long-term outcomes. Obviously, it's, when patients develop glaucoma, usually they have 20, 30, 40 years of treatment. And it's very important to have a long-term outcome for each treatment we have for patients. Even though literature is not so large for ELT, there are quite few studies showing long-term outcome of this procedure, and 2 of them showed in 2 separate cohorts of patients that IOP reduction obtained after ELT was either as standalone or combined with phaco could still be effective after 8 years of follow-up, which is very worth mentioning. What is also interesting to note with this surgical technique is that there are several procedures, several techniques to bypass the trabecular meshwork. But an interesting pending research question is still, do we really need to stent the trabecular meshwork to bypass and to allow the aqueous humor to go through the Schlemm's canal? And in case we do not need, as it's the case with the Elios treatment, it would mean that we could bypass the trabecular meshwork in a much less invasive manner for surrounding structure and for the long-term safety. So that's my understanding of the literature today available on the Elios and on this particular technique.
No, thank you. I think I'd agree with all of those sentiments. Marc, I mean, within these specific studies, I mean, just to try and draw you out on that a bit more, are there any of the other studies that you would really like to highlight that you find helpful to you, or do you think it's enough? I mean, looking at your, very, very significant case study that we've just talked about, I mean, I think there are shorter but larger case series, aren't there, from Durban?
There are.
And also one of your own, if I remember rightly.
Yeah, there are. I think very interesting is, I mean, you can say like all this 8-year data, that's just one group from one center that has been published. So you can question, like, is that data real? Surprisingly, around the same time in the same year, there was a second 8-year data published by a group of Michael Berlin and Ulrich Giers from Germany. They also had like 164 eyes, so like 3 eyes more than my study included. And they actually included 2 groups, ELT alone with 90 eyes and combined phaco plus ELT in 74 eyes. The data that they found, or the results that they found, IOP reduction, medication reduction, is quite similar to my 8-year data study. So that's kind of like reassuring that it's not only what I found, and it's because it's retrospective, maybe not comparable to the real world data. They had the same results. Another thing you can look at from this study is if you compare ELT alone to combined phaco plus ELT, they found higher IOP reduction and medication reduction in the combination group. And that's actually consistent with prior data that has been published from Funk and Wilmsmeyer, a group in Freiburg, Germany at that time in 2006 already, in a way smaller case series as well. So yes, I mean, it seems to be consistent what I told you, what I found, that other studies found it as well. And then we know like combined mixed procedures with phaco a little bit more effective than a standalone study.
Which is pretty much what we're seeing with all trabecular bypass procedures,
Exactly.
Things, isn't it? I mean, but I think what's interesting about that study, the Mike Berlin study, and I think there was another one, if I remember rightly, which was much shorter follow-up, we looked at standalone ELT. But I think what's interesting about that is that it's showing us it's the importance of that. Sorry, is that that's a standalone ELT trabecular bypass procedure, very non-invasive, no device left behind, no risk to endothelium, but that's still showing significant pressure reduction at an 8-year follow-up for a standalone procedure. And that's, to me, that's both medication reduction and pressure reduction. And that's really pretty interesting, albeit long retrospective and not a randomized controlled trial. That to me looks really pretty impressive data. What I'm looking forward to is seeing some RCT data to really complement this and supplement.
Yes.
And obviously the real world data has its role and has its value, but getting an RCT out there again, as we've got coming in the works in Europe, I think is going to be really powerful. Particularly as it's such a procedure with such a short learning curve. I think there's going to be a lot of rapid adoption, and I just hope that we can capture some of that data in the real world as well as that randomized controlled trial.
A couple more studies, smaller studies that I want to mention. Most of the data that has been published has been done with an older laser generation called the AIDA laser, which is not available anymore. And the newer studies in the laser that's currently being used was called ExTra laser, and then later has been renamed, is now on the market available as Elios laser. And that's why the procedure nowadays is called Elios procedure, because it's the only available laser at the moment. And we compared the 2 lasers with each other, like patients who underwent the ELT procedure with the AIDA laser and patients who went ELT with an ExTra laser in combination with cataract surgery. And we found no difference in the outcome between the 2 lasers. I think that's worth mentioning, because if people look at the data and they look into the manuscripts, they will notice that there are 2 different lasers being utilized to perform the procedure in the past.
Yeah, I mean, that's definitely a very important point from my perspective, in that when I first started looking into the data myself, I did find some of the change in terminology over the years and the different devices available. But essentially, you've got different names for laser, but you've still got an eczema punching a hole in the trabecular meshwork without collateral damage, without thermal damage, that gives you that same sort of crisp opening into the Schlemm's canal. I mean, it's the same laser, right? Is that correct?
Well, it's the same laser protocol and the
same kind of laser, same kind of physics going on.
There's another thing that I want to mention that kind of is based on what Cédric earlier said. It's nice to do something without an implant. And the eczema laser, it's the same concept as the laser we use for LASIK. So it's a non-thermal laser. When we do LASIK, we shave or reshave the cornea. You don't want to have thermal damage, what was called scarring in the cornea, because patient will complain they can't see afterwards. So as we know from LASIK, there is no scarring because the cornea remains clear after the procedure and patient have better vision than before. So ELT or Elios procedure is kind of LASIK for glaucoma. There's a study by Josic and colleagues from Hamburg in Germany, which actually had 3 arms comparing phaco alone compared to combined phaco ELT at that time and combined phaco trabectome. The trabectome device is an electrocautery device, which is basically doing the same. It's removing part of trabecular meshwork, exposing Schlemm's canal more to the anterior chamber where it's removed, but it's a thermal approach. And that study actually showed already after 1 year higher success rate for the non-thermal approach with the ELT laser compared to the thermal approach with the trabectome.
So, Cédric, what do you think in terms of these data and help in communicating with patients and what you're able to talk to patients and tell them in helping them make their choices? Does this help you with that, or are they just in France? Are they just very trusting and they say, "You tell me, doctor, you're the expert"?
Yeah, but what we know in the literature is that trabecular meshwork bypass techniques or procedures works in mild to moderate glaucoma. It helps to reduce IOP. It helps to reduce medication burden. It has been demonstrated in several studies. And the main advantage of this technique is that we do not use any device. And as Marc said, as we use an excimer laser, we expect no burning around the hole, and we create 10 holes, we observe these on 90 degrees of circumference of the angle. So, and that's the reason why long-term outcomes are still lasting after 8 years of follow-up. So I believe it's interesting to propose this procedure combined with phaco. Usually a patient needs phaco after the development of their glaucoma. And if you have the opportunity to reduce the medication burden and to reduce IOP, it is worth proposing it to patient. The other advantage of this technique is it spares the conjunctiva. So it means that if your patient needs in the future a conventional filtering surgery, you still can do it because you perform the procedure in the nasal area and only in the angle. And in the case the patient develop a more severe stage of the disease, you can still perform a filtering procedure. So I believe it's interesting for patients. The safety profile, we did not discuss the safety profile, but the previous studies showed that the rate of intraoperative complication is very low, and we do not expect complication during the follow-up at earlier stage or later stage of the follow-up. It's also interesting to mention to patients when you make the choice of a procedure.
For sure. I mean, that's one of the big things for me, I think, with all of this data and all of these studies, is that a very, very safe procedure with a very, very low complication rate. I mean, Marc, you mentioned pressure spikes, but those are small pressure spikes that at no greater rate than we're seeing with a standard phaco anyway. And I think a lot of the data in aggregate shows you a very, very safe procedure, which I think for me is very helpful for the patients, because it just lets me say to them quite honestly, look, you've got nothing to lose because it's a safe procedure, and you may well have a lot to gain and benefit. We don't yet know in whom the benefits are greatest. Some people do very, very well, some people less so, but on balance, it's well worth trying. Cédric, you mentioned the preservation of conjunctiva and conjunctival real estate for later surgery. I think that's always a powerful argument with MIGS. We all want to kick the can down the road, but in some of those patients, that surgical procedure, that glaucoma surgical procedure, will be needed. I think the other thing that's interesting with these types of precise excision procedures is that they don't prevent you doing potentially later supraciliary surgery. Thank you very much indeed for the time today, guys. That's been a really interesting and in-depth dig down into scratching the surface almost, but digging down into some of the the very powerful data that's out there around ELT as it stands now. And also, I look forward into the future, and we'll be back here again in not too many years talking about a wealth of RCTs and some of the comparative data in terms of diversity of patient populations and ethnicity. So thanks very much for the opportunity, Marc, Cédric, and I hope you enjoy the rest of your day.
Thank you very much.
Thank you, Gus and Cédric.
Thank you.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more details on this episode and to read the show notes, visit eliosvision.com/OUS/podcast. To learn more about Elios and contact us, click the link in the description. The Elios system Bausch & Lomb is manufactured by MLase GmbH and by WEINERT Fiber Optics GmbH. Elios is CE marked for use in adult patients with glaucoma and is currently under investigational use in the US as part of an ongoing IDE study by the FDA. The ExTra 2 Laser Class 4 has the brand name Elios. The ExTra 2 is equivalent to ExTra and AIDA devices. Please refer to the full disclaimer in the show notes.